So, about vestibular schwannoma. Vestibular schwannoma make up about 6 to 8% of all preliminary intracranial tumors and on 80 to 95% of cerebellopontine angle tumors. Most often, the place of the primary growth of vestibular schwannoma is vestibular part of the vestibular cochlear nerve and mainly the lower vestibular nerve. Less than 5% of the cases, vestibular schwannoma begin to grow from the auditory nerve. So, about tumor growth. Usually we speak to our patients and to our colleagues that 2 millimeters per year, it's the slow-growing tumors. But in literature, we can find that from 0.5 to 3 millimeters per year, it's slow-growing tumor. More than 10 millimeters, it's aggressive and rapid rate growth tumors. About 95% of vestibular schwannoma, the hearing impairment is not correlated with tumor size, unfortunately. It's very important. In pathology and histology, we all know that vestibular schwannoma is a result of proliferation of lemmacyte or so-called Schwann cells, as we all know. And the microscopic, it's two types of Antony 1 and Antony A and Antony V. Usually, vestibular schwannomas are at the working age group, and more younger patients, we work with neurofibromatosis. The incidence of vestibular schwannoma. You can see it here. But in almost all literature, we know that the percentage of the vestibular schwannoma is much bigger because of asymptomatic tumors. In 95% of cases of vestibular schwannoma, they are sporadic and only one side. About 5 to 10% of patients affect both auditory nerves or vestibular cochlear nerves, and they are associated with neurofibromatosis. We also know that vestibular schwannoma, one side or both sides, are a result of defeat of gene 22 chromosome, which producing the protein, the Schwann protein, and that's why we have these tumors. I want to say a few words about new classification. We all know that we have classification in 2016. It's almost the same in groups to these tumors. We have a little bit difference in melanotic schwannoma, and almost that's all. So we have the same classification in 2007 and 2016. I want to say a few words about classifications. These classifications are the world-known classifications which are useful for neurosurgeons, for radiologists, and for radiosurgery doctors. First classification which we use is classification by KNOSP, and this classification characterizes the topic localization and ratio tumor to the brainstem and to the first ventricle. Second classification which we use when we are working with patients with vestibular schwannomas is Gardner-Robertson classification of hearing loss. And we have several groups there. And the next classification is the world-known Professor Semi, neurosurgeon. I'm happy to meet him and to learn a little bit by him. he made classification almost similar to Knosp classification. So it's classification by localization. But he makes some subtypes. For example, 3A and 3B. And you can read it here. What's the difference? All these classifications are necessary to decide what we'll do with patient. So, when we are thinking about imaging, first of all, I mean CT or MR. First of all, we have to think, is there a tumor? If yes, where is it located? What is the density or signal intensity in the tumor? Is there necrosis, cysts, bone changes, dural tails, for example, and calcifications? What's how it's enhanced after contrast administration? Usually in our practice, we didn't use double dose. We don't need it. It's not metastasis. We use single dose. Then what we can make the differential diagnosis. I told you about the dural tail. When we have dural tail, we are thinking about meningioma, not about vestibular schwannoma. And what other imaging techniques can help us to make good diagnosis for the patient? So in neuroimaging, we have multi-slice CT. The machines are pretty quick. Magnetic resonance imaging, and there we have several techniques. First of all, we have conventional MR with contrast medium, and then we are going to advanced techniques, more modern one. We are talking about diffusion-weighted MR, diffusion tensor imaging, perfusion MR, perfusion CT, and MR spectroscopy if it's necessary in cases of vestibular schwannoma. For example, if we are talking about little part of aggressive and tumors. What we are looking on imaging, when we have a deal of the post-operation MR, is there a residual tumor? Is there radionecrosis, for example, if the patients already have treatment? Is there recurrent tumor or progression and pseudo-progression? I show you several classical MR techniques. It's for different machines, different manufacturers. Usually we use Philips machine in our hospital, and usually we work with balanced FFE. And I show you how it's look. So we can see here the place of growth, the first one, and then we can see the tumor. On this side, we can see both nerves, the facial and the vestibular cochlear or auditory nerve. So it's very convenient to use these techniques. And we also work with 3D drive technique and use it for radiosurgery. Here you can see the complex balanced FFE. We can see here more clearly it was for trigeminal nerve, T1, 1 millimeter per slice, and T1 with contrast. And also drive. I'm sorry, it's my patient. She's about 82 years old. It was asymptomatic vestibular schwannoma, 2 millimeter in diameter. And you can see how clearly we can see it in this technique without even contrast medium. Second, more advanced technique, we have diffusion-weighted imaging. From diffusion-weighted imaging, go diffuser tensor imaging. And we can see here there are vestibular cochlear nerve with small vestibular schwannoma and bundle of 7 and 8 complex of nerves. Unfortunately, we can't do tractography only facial nerve and vestibular cochlear nerve. Until this time, we can't do it. Next case, you can see 29 years old patients, the tractograms, how it goes through there and how it's damaged in the vestibular schwannoma, in coronal and axial planes, and we can see how it's go in the brainstem. Patients, sorry. Patient is 60 years old, and we have a more severe vestibular schwannoma with solid structure, and we can see there are the changes in tractography. What else we can do in MR? We can do pre- and post-radiation monitoring, and as you can see on this example, this is before radiosurgery, this is after 15 months after radiosurgery, and we check what's happening with brainstem on perfusion CT. Diffusion tensor imaging is the last knowledge what I know. It's to use like predictor with gamma knife. We use diffusion coefficient apparent like a predictor, and there is good conclusion. The loss of central enhancement after radiosurgery was common phenomenon, but it did not correlate with a tumor volume outcome. Pre-radiosurgical MR fits, including cystic compounds and ACD maximum values, can help us to be a predictor for treatment outcome. It's the most modern technique now. We can see here how it can be used. We see here before radiosurgery T1 with contrast medium. We can see here the ADC, and we can see here the value. And then after 12 months, we have bigger volume than before radiosurgery. So we have to decide what is it. In a 7.5 years after, we have shown the tumor is smaller, and the volume reduction ratio was -11.6%. The second example is patient with cystic and solid parts of vestibular schwannoma. It's not good usually, we think, for radiosurgery. We do ADC maps and have values much bigger than the previous one. In contrast medium, after 5 years, we have very good response, 92.6% reduction. What treatment options we have? We have usually 3 treatment options. First of all, we have microsurgical removal. But when we get radiosurgery, the microsurgical removal became less than radiosurgery and less than previous years. Then we have dynamic observation, wait-and-see strategy. And then we have radiosurgery or fractionated radiosurgery. My own experience is 270 patients with more than 77 months follow-up. So as we do with radiosurgery, we have to think and we have to memorize Professor Lexel, first of all, I think, because it's a beginner of radiosurgery era. And now we are working with this. And now in literature, we know that about 400 patients with vestibular schwannoma are treated in the world. When we are talking about radiosurgery, first of all, we have to think about the critical structures, well known, but I have to show you them. And about radiosurgery. When we go to lower dose, for example, from 10 to 12 gray, the result of radiosurgery of vestibular schwannoma became more great, and we have more great response, because the most maximum dose now for vestibular schwannoma is about 14 grains and no more. What we can do with MR in dynamic evaluation of tumor. Professor Pollock in the world goes 3 messages. The progression of process in cases that the tumor became more than 2 millimeters in one size bigger. The stabilization of the size, you can see it here. And tumor regression, then the tumor reduction is more than 2 millimeters. It's almost the rule now. And also we saw what's happening with accumulation of contrast medium and about the sizes of the tumor and volume of the tumor. I want to show you this message about cystic vestibular schwannoma. As I told you before, vestibular schwannoma with large cysts, more we go to the open surgery, and then we go to the next step, to the radiosurgery. In this last message, we saw that in microcystic group, the control rate in 2 years are almost the 100%, and the microcystic group is about 95%. So we can work with cystic vestibular schwannomas pretty well. And I want to show you our own cases. This patient is 31 years old with COS1 or SAMI1 classification. And we have in 13 months after radiosurgery, we have hyperperfusion and the bigger tumor volume. And after 24 months after radiosurgery, we have tumor reduction. And how it's look? Here we have small vestibular schwannoma. Unfortunately, small vestibular schwannoma usually have in Gardner-Robinson scale 4 or 5, so almost deaf patients. In 12 months, we can see it here. It's look a little bit bigger, and we miss, and there is central part without contrast medium. In 18 months, we have good response because we do perfusion MR and perfusion CT, and so that it will goes good. And after 24 months, there is the small part of vestibular schwannoma. Another case, COS2. This patient is deaf about 1.5 years, unfortunately, and she has headaches and some vestibular disorders. You can see how it looks before ISRS. It's COS2, and on SAMI it's also 2 class. And after 15 months, we have reduction in tumor size. And you can see it, how it looks here. Another patient with also COS2 on the opposite side, on the right side. After 12 months, we have reduction on half of the previous volume. And after 24 months, we have the smallest one. So it's the border of the previous before SRS. I have several minutes, I think, because we didn't have our colleague. And another COS2. In 6 months, we have pseudo-progression. And in 24 months, we have reduction of tumor. And the most difficult cases for radiosurgery, it's COS4. Because usually when we have COS3 and COS4, you have to operate patient by neurosurgeons and then to think about growing of the tumor after 3 months and 6 months. If it became growing, you have to do radiosurgery. This patient, she's only 52 years old, but she categorically refused from surgery. We can't do nothing in this. So you can see here the huge vestibular schwannoma with first ventricles goes to the other side. It's happening that she didn't have hydrocephalus. But in these cases, when we have hydrocephalus, first of all, we have to do shunting of the ventricles and then to think what open surgery or what we can do. We have in 12 months some drops without contrast medium. And you can see evolution in 6 months, in 12 months, and in 24 months after SRS. It became not bigger in twice for our happiness. And after 60 months after the surgery, we have at least stabilization of the patient. And I want to say a few words. We spoke with Michael that I have to do it about theoretical risk after radiosurgery of malignant transformation. Unfortunately, it's not zero, unfortunately. It's, you can see the value, it's theoretical value of malignant. And in another literature, we can see, because here's a lot of patients and a lot of years, and we have in 1, 3, and 5 years, the percentage of malignancy 0, 0.1, and 0.1. So it's not zero, but it's very, very small, and we have to keep in mind because we are working with radiosurgery. And at the end, I want to thank to Michael Chernov, to Maris Skromanis, to Linda Tsepenia, and to Vladislav Budik for such event. And my last words in this speech are here. I think we are all working for the patient. Thank you very much.